First of all, we just want to say welcome to all of our participants. We are excited that you have joined us today for the DSMT Mechanics of Reimbursement and the Role of Chronic Care Management for FQHCs and RHC version. Thank you so kindly. My name is Jean Drummond with Healthcare Dynamics International, and I am delighted to now allow for the purpose to turn it over to Mrs. Sue Beath, who is the Diabetes Program Coordinator for the Center for Chronic Disease Prevention and Control of the Maryland Department of Health. Sue? Okay, Sue?
Sorry about that. Can you hear me now?
No. Yes, we certainly can. Thank you so much for joining us, please.
Before we begin with the content of this webinar, I just wanted to let you know about a funding opportunity in eMaryland Marketplace Advantage for an FQHC and a pharmacy to develop a DSMES program. Please visit www.procurement.maryland.gov to view this opportunity. The solicitation number is PHPA-804 BPM 015922. We will not answer any questions about this RFP on this webinar. Any questions must be sent in writing to the contract officer named on the RFP. The questions we will entertain on this webinar have to do with the content that Tim McNeil will be presenting today. Thank you.
Thank you so very kindly, Sue. And so next, we are delighted to introduce to you Mr. Timothy McNeil, RN MPH, as he shares with us his expertise related to this topic. Thank you so much. We'd also like to let you know that if you have questions, kindly type them into the chat box, and we will answer the questions as we move forward, specifically the questions related to the presentation, the content that Mr. McNeil will share. Tim? Yes, Tim?
Hi, I'm sorry. I guess my phone was on mute. It's a pleasure to talk with everyone today. I'm going to be providing quite a bit of content around the Diabetes Self-Management Training, or DSMT benefit, specifically to the role of federally qualified health centers or rural health centers. And also we'll touch on the way that the chronic care management benefit also can support persons with diabetes that are going through the programs. Of particular note, particularly since this is a focus group of FQHCs that are based in Maryland, or at least have facilities in the state of Maryland, is that with the Total Cost of Care initiative, there's quite a bit of focus on diabetes as well as behavioral health issues. And there's some, in addition to the funding opportunity that was announced to the health department, there are other opportunities specifically focused on diabetes that HSCRC is also announcing. So really stay tuned, because it seems like there's a united front across the state to really look at diabetes, and accredited diabetes programs will have the most success of being sustainable long term. Next slide. So I'm going to go through the accreditation requirements, the role of chronic care management. I will touch on telehealth, and although there's a placeholder at the end for questions and discussions, I would like to field your questions as we go through, so that if a particular topic comes up that you would like a greater elaboration on, I'd like to address that at that time. Next slide. So essentially, supporting providers and empowering patients with diabetes is an essential part of the entire care continuum. And when it comes to the management of diabetes, there's common themes that are expressed often by healthcare providers. Clinics very busy. Lifestyle modification is a very difficult task. Standard office visits don't cover the cost of providing additional support. And so therein lies the opportunity where you can provide greater support and education to patients and be compensated through these means. Next slide. So the better disease self-management, if we can achieve improved disease self-management for the population with diabetes, then we will get these outcomes: improved quality of care, better metabolic control, improved lipid levels, reduced blood pressure, improved A1C. In addition to that, as you all know, there's been a significant push by HRSA, the Health Resources and Service Administration, to make sure that FQHCs are able to obtain certification as patient-centered medical homes. Accredited programs that incorporate diabetes self-management education, it aligns very well with the NCQA requirements for patient-centered medical home. So in addition to the great clinical outcomes, if you have or are seeking PCMH designation, then having these types of programs embedded in your delivery model will add favor to your quest for sustained accreditation under PCMH model. Next slide. So the diabetes self-management education components, so the key components are with diabetes self-management education and supports, things such as healthy eating, being active, disease monitoring, problem solving, healthy coping, reducing risk, and medication management. So these items will be part of a curriculum that will be delivered to patients that are referred into a diabetes self-management training program. If that program is accredited under your FQHC, then after you obtain accreditation, you'll submit for recognition with the MAC, and then you will be able to receive reimbursement for those services. And I'll go into greater detail about the complexity of billing. And I am very aware that FQHCs have and rural health centers have a different payment model than a traditional provider. And we'll speak specifically to the requirements that apply to FQHCs in obtaining reimbursement, both for DSMT, diabetes self-management training, medical nutrition therapy, which is often delivered as a companion service to diabetes self-management training, and chronic care management, which is ongoing non-face-to-face support for patients that are also challenged with the management of their diabetes. Next slide. So the benefits that diabetes education offers to the patient. So we kind of outlined the benefits to the practice, the benefits to the health center. In addition to that, the benefits to the patient are receiving individualized education and management guidance by a team that's wraparound services, in addition to the clinical support that they're getting from their physician or provider at the clinic setting. Group support from other individuals living with diabetes, personalized care plans, and flexible appointment times. I think one of the most powerful things, I had an opportunity to help deliver a diabetes self-management education class in the Mississippi Delta. And we targeted that class to the needs of the population. In that population, it was an FQHC population that also suffered from social determinants, primarily low-income African-American. And the feedback from the group was that traditional diabetes education does not show them how to manage their diabetes, and particularly their diet, on a food stamp budget. And they requested that we name the program How to Manage Your Diabetes on a Food Stamp Budget. We were a little bit fearful of using that nomenclature, but they decided that they wanted, the population said that. And when we did, we had an overwhelming response. There was a line out the door where it was people wanted to understand not just how to manage the diabetes, but how you fix it to me. I have this amount of food stamps every month, and every month I run out. And then what do? I go to the food bank. Many of them said we go to the food bank and we get oodles of noodles, which definitely does not fit into the dietary practices. So this type of education that can be customized to the needs of the population and be able to trigger reimbursement for the FQHC becomes a win-win for the beneficiary as well as the health center. Next slide. So DSMT accreditation. The first step is to obtain accreditation. The purpose of accreditation, CMS, the Centers for Medicare and Medicaid Services, require every program that bills for the diabetes self-management training benefit to be accredited. And there are two national accrediting organizations. One is the American Association of Diabetes Educators. The other one is the American Diabetes Association. either one, they're equally recognized. Once accreditation or certification is obtained, then the organization would submit proof of accreditation to their MAC, their Medicare Administrative Contractor, and then they have recognized status. So they would be a recognized provider to be able to bill for the delivery of diabetes self-management training to Medicare beneficiaries. Although that's the process for Medicare, Medicare Advantage, Medicaid, many Medicaid plans, as well as many commercial plans also have mirrored the same process where they also are requiring accreditation from one of the two national accrediting organizations. Then organizations would be recognized to bill for those services. So they've adopted the same regulations that CMS have established. Some of the curriculums that are being developed are things like the Stanford model, which now is no longer called the Stanford model, but the Self-Management Resource Center manages the licensing of that program. It is a program that is currently active throughout the state of Maryland, but there are other curriculums that an organization can deliver that will be able to achieve the accreditation requirements and receive reimbursement when billed according to the process. Next slide. Next slide. I covered this content before in the last slide. So the two approved organizations, so the timeline, and it's important to know the timeline. So the American Diabetes Association was an approved national accrediting organization in 2002. The American Association of Diabetes Educators was not approved until 2009. So therefore, between 2002 and 2009, any health system or provider that wanted to deliver diabetes self-management training, their only option for accreditation was the American Diabetes Association. So many hospitals have the same accreditation that they obtained initially because that was the only way they could get accredited was through the American Diabetes Association. The Indian Health Service used to provide an accreditation. They no longer do. So any Indian Health Service sites have to go to either the American Diabetes Association or the American Association of Diabetes Educators in order to obtain accreditation. Both organizations, both national accrediting organizations, adhere to the 10 national standards for diabetes self-management education and training. And those 10 national standards are revisited every 5 years. And so every 5 years, there's an update. The most recent update was 2019. And so we now are operating under the most current standards. And those standards outline all of the steps that an organization must adhere to in order to be accredited. So the basis for preparing for accreditation is outlining each of the 10 national standards, making sure that your program adopts those 10 national standards in the delivery of diabetes self-management education and supports. You're able to deliver at least one test class to show that you're able to deliver the model, and under that, deliver the model of diabetes education according to the 10 standards, and then have documentation proof that you were able to deliver it that way. That would be submitted to the accrediting organization that you choose to get accredited with, and then they will schedule either a telephone interview or a site visit where they come and then review the program. The purpose of the site visit or the telephone interview is to hear the program verbally state how they deliver the diabetes self-management education and supports to ensure that what processes and procedures that they had outlined on paper is actually what's in practice, and that's the purpose of the interview as a two-step accreditation review process. Next slide. So the curriculum, you have to implement a curriculum, and that curriculum must adhere to the 10 standards. Examples of curriculums that are commonly used is the Stanford model or the Self-Management Resource Center. DEEP is another one, Diabetes Empowerment Education Program. AADE has a curriculum that they offer. ADA also has a curriculum that they offer. And so an organization could choose any of these, and there are others. So this is not an exhaustive list. This is just a sample of some of the curriculums that do meet the 10 national standards. And I've worked with organizations that deliver programs with each of these curriculums, and all of those programs were able to successfully obtain accreditation, begin billing for services in their quest for long-term sustainability. I think the important thing to think about in reviewing the options of curriculums is each curriculum is a little different. They have the same general content, but their approach to the delivery of the content and the requirements that they put in place and how the content is delivered differ. So it's important for organizations to understand their options, look at the needs of their population, and then adopt the program model that fits. Just to give you one example, I was working with an FQHC in Detroit. So the FQHC in Detroit was seeking accreditation. The Stanford model is one where the program requires the delivery of the education lasts for 2.5 hours once a week over the course of 6 weeks. This particular FQHC had a site that primarily serviced behavioral health populations. And so they recognized very quickly, if I have a population of patients that have a diagnosis of schizophrenia, many of which have a diagnosis of diabetes as a comorbidity as a result of long-term psychotropic use, those people needed diabetes education, but the ability of 15 patients with schizophrenia to sit in a class for 2.5 hours was not possible. And so we had to look at other options of curriculums that allowed the FQHC to deliver the class in short, bite-sized chunks that would be adaptable and usable by a population that was served by that particular health center. Next slide. So potential gaps in the national standards between what some organizations are using if they have started to implement a curriculum. First, there needs to be a policy and procedure manual. And this policy and procedure manual needs to be specific to the delivery of diabetes self-management education at your center. So I'm sure every FQHC has a range of policies and procedures. You would have to establish a separate set just for this program. And like many health centers, sometimes if you're adopting new policies, that may have to go through a policy and procedure committee, then it has to get signed off by the board. So if those things are requirements at your center, you have to factor that timing in to your accreditation process, because you can't go forward to seeking accreditation until you have fully operational approved policies that the board has allowed the organization to implement. And I just highlight that because I had an FQHC that went forward seeking accreditation, but the board had not yet approved their policies and procedures. So then when the accrediting organization came to review, we weren't able to give them an approved policy, which obviously fouled up the process. You need to have stakeholder input to promote quality. Many FQHCs are very familiar with that, but you have to have a separate committee meeting at least once a year that comes together to promote quality, where they look at what are the clinical outcomes based on the diabetes curriculum that's being delivered now. What are suggestions on ways to improve it to target the needs of our population? Then we will look at the suggestions from this group and then adopt some, or may choose not to adopt them. That will be encapsulated into minutes, and those minutes will be stored and recorded. And then we will have that available every year, at least once a year, where those have been documented and we review our clinical outcomes. That is a requirement of obtaining and maintaining accreditation, and it would have to be adopted as part of your organization if you're going to obtain accreditation. Diabetes self-management education instructors, there needs to be at least everyone that's participating in the instruction activity has to obtain continuing education that's specific to diabetes. There does need to be at least one licensed person that's overseeing the program as well, and they too have to have at least 15 hours of continuing education that is specific to diabetes or diabetes related. And so the first thing that may come to your mind, well, all of the nurses in our clinic, all the dietitians in our center, they have to maintain continuing education units to maintain their license, so we should be automatically be meeting this requirement. Well, nothing hurts worse than we go through all this work and then we get to the final step and we find out, yes, Nurse Johnson has 15 hours, but 5 of those hours were related to COPD and not related to diabetes. So you have to make sure that everyone has 15 hours. Now, there is a recognition that community health workers can contribute and be active participants in delivering diabetes self-management education and support. And they can be covered as part of the delivery model and reimbursed. However, those persons also have to maintain 15 hours of continuing education. Well, your community health workers most likely are not licensed if you have community health workers or promoters or, or however they're called. Even if they're not licensed, they need to have at least 15 clock hours of continuing education. It does not have to be formal education that is, released by the area health education center, but it does have to be 15 clock hours, and it can be achieved simply by having an in-service once a month that maybe the RN in the clinic provides an in-service on a topic about diabetes. There's a start and stop time. The topic is listed, and then there's a sign-in sheet that then goes as part of the record to show everyone that participates in the delivery of diabetes self-management education has obtained their continuing education requirement. There does need to be an individual assessment and plan specific to diabetes, ongoing support, such as a person may be encouraged to increase their physical activity, but they may be living in an environment where it may not be safe to have regular physical activity. So identifying resources where you could refer them to, maybe it's a local YMCA or local senior center, or there's a community where there's a track where they can walk. So those are the types of things and that would be incorporated into an ongoing support plan, and that would be required documentation as part of every education record that goes through this accrediting process. And lastly, there must be a continuous quality improvement process in place. Next slide. Program fidelity. It's important to maintain program fidelity. So when you adopt a curriculum, most curriculums have a requirement on these are the ways that services are delivered. You have to adhere to that in order to maintain your accreditation. Because if you adopt a curriculum and then you have significant variance in the way you're delivering that curriculum, then that could put in jeopardy your accreditation. If an organization loses their accreditation, then they are required to notify the Medicare administrative contractor, because at that point, until their accreditation is renewed, they are no longer able to bill for diabetes self-management training. Next slide. So the role of community health workers prior to 2012, community health workers, promoters, lay leaders, they were not recognized formally as a person that can support the delivery of diabetes self-management education and support. The standards were changed in 2012, and it was based on a policy brief that was released by the Centers for Disease Control and Prevention, which essentially highlighted the fact that without community health workers, in many groups, there will be no way for them to receive diabetes self-management education. And so the organization that establishes the 10 national standards took that into account, and in 2012 formally recognized the role of community health workers in the delivery of the education. And so now accredited diabetes self-management education programs can have community health workers, lay leaders, or promoters be part of the team that's delivering education, and then that time counts towards billable services. Next slide. The pathway to reimbursement. The first thing is to obtain accreditation. Accreditation requires delivery of a curriculum based on the 10 national standards. Once accreditation is received, the program must submit for recognition, which is simply sending proof of accreditation to the Medicare administrative contractor. When, say, an organization, FQHC, submitted for accreditation with AADE, the American Association of Diabetes Educators. At the end of their interview, then they were told that they passed. Within a week, they will receive their accreditation certificate in the mail. There's a control tracking number on that, and the name of the health center is on the accreditation certificate. We'll send a copy of that accreditation certificate to our Medicare administrator contractor. And then at that point, upon receipt of the certificate by our Medicare administrator contractor, we are then a recognized entity that's able to deliver diabetes self-management training, and we can be reimbursed from the MAC. Next slide. So program considerations. I often hear a myth that accredited programs require a certified diabetes educator. It absolutely does not require a certified diabetes educator. It's a nice to have, but it's not a requirement. And it's not a requirement partly because there's not enough certified diabetes educators to go around. If we limit this education only to certified diabetes educators, very few people would have access. And nationally, we have a problem with access and utilization of diabetes self-management training benefits now. So Medicare, CMS, they did a 10-year retrospective review looking at real live claims data of every beneficiary in the Medicare program nationally that has a diagnosis of diabetes. Then they did a second look to see, of those persons with a known diagnosis of diabetes, how many of those persons use their 10-hour benefit for diabetes self-management education and training. And they found that 5% of persons with a known diagnosis of diabetes actually use their benefit. So there clearly is a problem that we are upside down in this country because there is a dialysis center on every corner that's treating the complications of diabetes, but there's only 5% of the population that's receiving diabetes education to prevent complications related to diabetes. So we need more people to be delivering these services, and that's why there's reimbursement for it. Other program considerations: DSMT, diabetes self-management training, and MNT, medical nutrition therapy, can be provided in a joint education class. However, DSMT and MNT cannot be provided to the same beneficiary on the same day. I have no idea why that is the case. There's been a lot of advocacy to CMS to change that policy. There's been a couple of bills that have been drafted to change that policy. There's one working its way now through Capitol Hill. Unfortunately, I don't think there's going to be any bills moving anytime soon. But do know that there's advocacy trying to get that policy changed. And next, this is a Medicare benefit. Sometimes organizations begin providing services such as these using a grant. And with many grant programs, you may provide incentives for people to come to classes. Like very common where I've been to sites where they were giving out Walmart gift cards and other things to get people to come to classes and complete, which sounds great for a grant. But once we start billing for services, we can't provide monetary gifts to beneficiaries so that we are able to then bill the Medicare programs for their services. So those things have to be taken into account. Next slide. So additional program considerations for Medicaid and Medicare Advantage populations. Medicaid beneficiaries in many states, and Maryland is one, where there's requirement for Medicaid managed care, except for duals, where dual is a person that has Medicare as a primary, Medicaid as a secondary. So generally for dual eligibles, they're not in a managed plan, and they still have Medicare as their primary benefit, so you would continue on. Well, in Maryland specifically, diabetes self-management training is not a mandatory benefit under Medicaid. It is an optional benefit for states. Some states have adopted it and said, yes, we will cover it. Other states have decided not to. And so Maryland is one that is not. So that means that when it comes to Medicaid population, it would be a negotiation with the Medicaid managed care plan about whether or not they want to cover diabetes self-management training as an optional benefit for their members. However, all Medicare beneficiaries, to include dual eligibles, have this as a covered benefit. And so you may question in your mind, well, if a person is a dual eligible, they have Medicare as their primary, Medicaid as their secondary, will we seek reimbursement from Medicare and then get a denial from Medicaid as a secondary because Maryland Medicaid does not cover diabetes self-management training? So the question is, the answer is no, that you will not get a denial. You should not get a denial because every state has a statutory requirement to pay the co-insurance or the secondary payment for a Medicare, a dual eligible beneficiary, even if that benefit is not an established benefit under Medicaid in that state. And we have a copy of a notice that CMS sent to all Medicaid directors, giving them a friendly reminder of this statutory requirement. And that was at the behest of many organizations that were getting denials from state Medicaid for the secondary payment, although they were statutorily required to pay. Medicare Advantage, Part C plans, Medicare Advantage plans, all Medicare Advantage plans are required to cover everything that Medicare, original Medicare covers. Diabetes self-management training, medical nutrition therapy are both mandatory benefits under the Medicare program, which means every Medicare Advantage plan has to cover them as well. So it's not optional. What is optional is the Medicare Advantage plan doesn't have to let an organization in their network, but they do have to cover this benefit for all their beneficiaries. Generally, I've never run into a Medicare Advantage plan that stated that they were overrun with too many diabetes self-management training organizations that were accredited and wanted to provide education for the population. So getting paneled with a Medicare Advantage plan and reimbursed under this model is generally not a task, but they most maintain the same accreditation requirement that Medicare requires. Next slide. So the history of the benefit began in 2002. It is a 10-hour benefit. As a 10-hour benefit, the way the benefit is structured, there is 1 hour of individual time and there's 9 hours of group. FQHCs and rural health centers are only able to be reimbursed for the individual one-to-one time. So although the benefit is a 10-hour benefit, there's 1 hour of individual, there's 9 hours of group. The FQHC or rural health center can only be reimbursed for the 1 hour of individual. You cannot be reimbursed for the 9 hours of group. Now, you may instantly say, then I'll only provide the 1 hour of individual. If I were to do this, I would never do the 9 hours of group because I can't be reimbursed for the 9 hours of group. Well, it's a dual-edged sword. So the other side is an organization has to maintain accreditation or you cannot bill. The accreditation requirements require individual and group. So then you might be saying, well, why in the world would CMS say we have to maintain accreditation, which means we have to do individual and group? They have a model where you're paid for individual and group, but we can't partake in the group. We can only be paid for the individual. Well, the rationale is because of the all-inclusive payment model for FQHCs or wraparound or however you phrase it, FQHCs get an enhanced payment. If you look at the way the benefit is structured, FQHCs will be able to obtain equal, if not more, reimbursement than a traditional provider based on the way they deliver the service. First, I just want to highlight the hour of individual. The hour of individual benefit is billed in 30-minute increments. So that means for a traditional provider, if they do an hour of individual diabetes self-management training, they would bill for 2 units because it's billed in 30-minute increments. Then they would be paid for both units of service. For an FQHC or a rural health center, because of the all-inclusive payment model, if you bill for 2 units, you're paid 1 payment. If you do 30 minutes today and 30 minutes next week, you're paid twice your all-inclusive rate. So it would behoove you to space that out so that you're able to then obtain reimbursement for both units of service rather than do a full hour in one day, because then you're paid only 1 all-inclusive payment, but you did the same service just one time. You split it over 2 days. In addition to that, medical nutrition therapy is a 3-hour benefit that's often done as a companion to diabetes self-management training. I told you in an earlier slide, diabetes self-management training and medical nutrition therapy can't be delivered at the same time, just not to the same beneficiary on the same day. It cannot be billed to the same beneficiary the same day. So I have FQHCs that their delivery model includes 30 minutes of an individual session. The beneficiary comes back on another day for another 30-minute session. Then we will do 9 hours of group. And during the 9 hours of group, I will have individual sessions of medical nutrition therapy that's sprinkled throughout the 9 hours of group DSMT. I deliver the 9 hours of group DSMT so I meet my accreditation standard. But since I cannot bill and be paid for the 9 hours of group, I am able to bill for my medical nutrition therapy. And so my business model becomes DSMT, all-inclusive rate payment 1. And on average, the average payment, all-inclusive payment per HRSA is about $175. Obviously, organizations fall everywhere on that continuum. But if we take that average all-inclusive rate of $175, Tim's FQHC, we deliver a 30-minute individual session of DSMT today, I get $175. I bring the beneficiary back next week, I do another 30 minutes, I get paid $175 the second time. Then they go into my group session, and then I bring that person out of the group session. I have a 15-minute session with the dietitian for medical nutrition therapy. I bill another $175. I then have a follow-up session the next week with that beneficiary with the dietitian. I bill that under M&T. I bill for the fourth $175. So you see how I now have eclipsed the payment rate of a traditional provider that's able to bill for individual and group, but I have a model that incorporates other services that allows me to obtain reimbursement. So that's why the FQHC is not or rural health center is not able to bill for the individual and group, but you could establish a delivery model that meets the requirements and is able to generate the same, if not more, revenue than a traditional provider. Next slide. I wanted to go into that detail because I know that the payment issue is generally a hard thing to get by with many federally qualified health centers and rural health centers. This is a Part B benefit for diabetes self-management training. So as a Part B benefit, co-insurance payments do apply. And so that the discussion I had earlier about I have a dual eligible person that has Medicare as a primary and Medicaid as a secondary. I would bill Medicare for 80%, and then I go to Medicaid for the co-insurance payment. That is customary. One thing to note, medical nutrition therapy, no co-payment, co-insurance, or deductible applies to medical nutrition therapy. So CMS pays that at 100%. So again, in that delivery model that I described, when I go to begin delivering medical nutrition therapy as a companion service to the diabetes self-management training group sessions, I would be getting the full all-inclusive rate for Medicare for that service, and I would not have to bill the co-insurance to Medicaid if I was serving a dual eligible. Next slide. I've gone in great detail about the breakdown in the hours of training, so we'll go to the next slide. One thing I did want to highlight that was on that last slide was pre-diabetes. So there is a Medicare benefit, as many of you are aware, for diabetes prevention. So this benefit, diabetes self-management training, medical nutrition therapy, is limited to persons with an actual diagnosis of diabetes. So pre-diabetes, I think I got sugar, I heard I might have sugar, none of that counts. They actually have to have an actual diagnosis of diabetes that's proven in the record in order for them to receive this benefit. Next slide. So this is a CMS definition of diabetes. So just note that this is the definition that's used. I've been at health centers and they were like, well, we put everybody in the class that's taking metformin. Well, you do know, as I explained to them, you do know that sometimes patients are placed on metformin as a pre-diabetes intervention. So just because they're on metformin doesn't mean they have a diagnosis of diabetes, nor does that meet the criteria for CMS for you to bill for the service. So it has to be more than just they're on metformin. So now they're in this class. Next slide. So what is required prior to the start of service? There does need to be a referral. So there needs to be a physician or provider referral for diabetes self-management training service. And it needs to be very specific in that it states that this person should receive 1 hour of individual, 9 hours of group, and 3 hours of medical nutrition therapy. And the order obviously needs to be the day of or prior to the first day we're doing billable services. Can't be dated afterwards. And if that person has Medicare Part C, obviously we need to be paneled with that Medicare Advantage plan in order to bill for those services. And then lastly, which is very customary for federally qualified health centers, is that you have to verify that person's secondary payer. And, yes, sliding scale processes do apply. So I know many health centers have a process in place where they collect the 80% for Medicare. If that person has no secondary insurance, then they're able to then apply the 20% co-insurance to their approved sliding scale, and then the person pays based on where they fall in that sliding scale requirement. So that is acceptable and recognized by CMS as a process that FQHCs can adopt to slide off the supplemental or the co-insurance that's required. Next slide. Accreditation versus recognition. Excuse me. So the accreditation process is the formal process we go through with one of the two national accrediting organizations. Recognition is simply sending the proof of accreditation to the Medicare administrative contractor. I can't highlight that enough because you will not believe how many organizations I encounter that reach me and say, I did everything and I'm not getting paid. And then we contact the Medicare administrative contractor only to find that proof of accreditation was never received. And so therefore, every one of their claims continued to be rejected and they did not know why. So you have to complete that final step. Next slide. Sequence of services. Medicare Part B covers 10 hours of diabetes self-management training services. It's important to note that that is a lifetime benefit. And so once the person's used their lifetime benefit, they can't use it again. By the way, that's another thing that there's a lot of advocacy for to change. But as of today, it continues on. However, do not be too concerned because Medicare has proven that only 5% of the population with a diagnosis of diabetes ever use any of their benefit. So it's very unlikely you'll be overrun with a bunch of people that have already used their benefit that are coming for classes. However, you should be cognizant of the fact that it is a lifetime benefit. And one last thing, lifetime benefit means that the full 10 hours cannot be repeated because it's a lifetime benefit. However, there is a refresher benefit or refresher diabetes self-management training benefit that's available to a beneficiary once they've used their lifetime benefit, which is 2 hours of diabetes self-management training. And then medical nutrition therapy also has a refresher benefit of 2 hours. So again, looking at that combined delivery model, your group of patients with diagnosis of diabetes go through the 10 hours this year. Then next calendar year, I can bring those same people back and they can get 2 hours of a refresher diabetes self-management training benefit and 2 hours of medical nutrition therapy. And then that could be billed to their benefit. Next slide. Key organizational issues. So this is important to establish a business model for diabetes self-management training. You don't want to go through all this work to get accredited, get recognized, set the structure up, establish policies and procedures, only to then have a failing business unit. So you want this to be a profit center within your organization. So one of the things you want to do right away is assess market demand, assess the ability of current programs in your market to meet that demand, understand how those services will be billed, and if you're partnering, identify models that make this program delivery mutually beneficial. So I just highlighted that HSCRC the Maryland Rate Commission is focusing on diabetes. They are pushing information to health systems across the state of Maryland that are in the total cost of care. And they're saying that diabetes and depression and behavioral health are major priorities. And there's going to be funding through HSCRC to support the delivery of expansive diabetes self-management training programs. And so there could be a model where the FQHC partners with the hospital, defines the partnership where there will be referrals driven from the health system to the FQHC. There'll be community-based delivery of diabetes education outside of the hospital, which could then be to the benefit of the total cost of care model. Next slide. So the primary payers, I've outlined this: Medicare Part B, upon which co-insurance requirements apply, Medicare Advantage plans, Medicaid managed care plans. That's an individual negotiation in the state of Maryland because they're not mandated to cover it. And then lastly, commercial insurance. Most commercial plans do cover this as a benefit. Next slide. So in 2019, there were rate changes, and rate changes occur every year. And when those rate changes occur, they're retroactive to January 1. But as you all know, FQHCs and rural health centers, you have an established all-inclusive rate. And so that process takes precedence in terms of how you bill for services. Next slide. Excuse me. So these are the CPT HCPCS codes for diabetes self-management training and medical nutrition therapy. And so you see the first two codes, G0108 is for individual diabetes self-management training, billed in 30-minute increments. And then an FQHC that did that would bill G0108. They bill for that 30-minute, they would get their all-inclusive rate. They bring the person back, they could bill for the second unit of the hour benefit for individual. The 9 hours of group are not reimbursable at all. But if you attempt to bill for group the same day you bill for M&T, your claim will get rejected, even though you couldn't be reimbursed for group. The only reason you need to deliver the group is to maintain your accreditation. And so that's why many FQHCs opt to deliver DSMT individual. They deliver the group, they document the group that's being delivered as part of the clinical record. They maintain documentation of that for their accreditation review. And then they also deliver M&T and they bill for the M&T. Next slide. So business model, it's important to outline what your business model is and then establish what the break-even point for that business model is, and then think about how you would incorporate M&T and DSMT. One thing that I do want to note about the RFP that's out, part of the RFP, in addition to funding that's available, is intensive technical assistance. And so some of the technical assistance that will be made available through the state is that myself as a consultant would be working with an organization that receives that award to define what is your delivery model? What's the best curriculum that meets the needs of your population? What's our break-even point? So do we need to deliver 5 classes a year, 6 classes, based on your expenses? We'll look at your actual expenses. We'll look at your actual all-inclusive rate. And then we'll develop a business model for break-even that's worst-case scenario and best-case scenario. So you could all of that would be part of the package of support that you would receive in this process, in addition to assistance with achieving accreditation, and then establishing those referral patterns and partnerships with providers like hospitals that are being pressured by the Rate Commission to expand diabetes education to maximize the driving of referrals into your program so that the program will not just break even, but be a profit center within your organization. But it's very important to always approach worst case models and best case, so you know that at least when the worst case scenario, if we're able to meet that criteria, then we know we at least break even. So that's always an important thing to prepare for. Next slide. So the cost of the programs is essential that the program determine true cost. That's why I said part of the work that I would be doing with a health center that needed assistance would be identifying what are your true costs, what is your all-inclusive rate, we would establish a budget for the program. We'd establish break even. We'd look at the referral patterns. And so you need all of that information in order to make a sound decision about doing these services. But generally, as long as we can establish enough referrals, because healthcare is all about volume, it's a volume business, then you can meet and exceed break even generally in most cases. Next slide. Program budget. So as I just described, we usually begin with expenses because the revenue is fixed. You're not going to move your all-inclusive rate until you have that new negotiation. So then if the rate is fixed, the only thing that we can do to change the revenue is to adjust the volume. If the volume decreases, our profitability or likelihood of profitability would decrease. If our volume increases, then our profitability goes up. If our expenses go up, that also impacts. So those are all of the things that we would be working together on. We would be putting that into a spreadsheet that would allow you to adjust the numbers. So the numbers would flow through and you could play with it, or you could make adjustments on expenses or up and down on the volume to get to a point where the break-even point would be one in which you felt comfortable with and would be attainable realistically based on the need for the services within your target market. Next slide. So break-even point is very important, and I usually start there in doing any type of budget because we want to know very quickly, excuse me, what it will take to get to break-even. I've had organizations where they had very significant costs, and because their costs were so high, the break-even point was very, very high. And we decided at that point, it's not possible for you to reach break-even because the number of referrals you would need would exceed anything that you've ever been able to do. So the only way to make this work was to go back and rethink how we are paying for the staff that are delivering the service. That particular center, they decided to incorporate contract staff. They pay it on a per diem basis, and then they were able to negotiate to bring their costs down significantly to get to a break-even that they felt more comfortable. In this break-even analysis, you should plan for attrition. So for a group class, group sessions, CMS defines a group between 2 and 20 persons. And so we wouldn't make our break-even thinking that every class is going to enroll 20 people. We have to plan, have 20 people complete all the defined services. So we'd have to plan that there would be some people that may start, and then there were people that will drop off. And that's also an important factor to measure as part of your continuous quality improvement program. You need to know what is the completer rate, meaning the number of people who sign up and enter our program and actually complete and receive all of the services that we define for them. And then you need to track what that percentage is over time, and then see what interventions we can do to improve that percentage. In addition to seeing the number of completers, you also want to know when people drop. So if I have a billing model where I expect everyone to receive 6 billable units of service over the course of 8 weeks, and if I am consistently having people drop after the 3rd service, I need to find out what is causing people to drop. What can I do differently that will cause them to complete or at least extend beyond 3 to 4 or 5, because that all changes my break-even point and business model. Next slide. So some of the break-even questions, like I just highlighted, can we realistically meet those break-even? Is the volume realistic? What can we do to reduce expenses? What can we do to increase demand? So volume business, we need demand. Hospitals are taking risks for patients with diabetes, and do know that most people that are diagnosed with diabetes in a hospital do not want to return to that same hospital to sit in that sick place to get their diabetes education, which contributes to the low numbers of people that actually receive diabetes education. Yes, I'm very aware that most hospitals in the country have an accredited diabetes education program, and they touch a very, very small fraction of the population that have a diagnosis of diabetes for all of the reasons that I just stated. I mean, sometimes you got to pay to park. There's nowhere to park. You got to walk a mile through the parking garage to get in just to get my education, no thanks. But if I was able to go to a nice, comfortable community setting in my neighborhood, to a health center, receive the same quality level of education through a partnership between the health system that's taking risks for that person and the FQHC that can deliver the education in a more comfortable setting, then that becomes a win-win for both organizations. Next slide. Chronic care management. So it is a very underutilized service amongst FQHCs and rural health centers is chronic care management. And part of that is because when the chronic care management benefit began, FQHCs and rural health centers were excluded from doing the service. So it took a while for CMS to figure out a way to change the rules to allow FQHCs and rural health centers to begin to deliver the service. And now those rules have been set, and I've worked with multiple FQHCs and rural health centers to begin assisting them with implementing this model, but there's still been low adoption. And so I wanted to take this opportunity just to highlight the fact that not only should you be considering incorporating chronic care management as part of your delivery model, but definitely even incorporating it as an adjunct to your diabetes self-management training. So it would be great to be able to deliver jointly, and it increases your profitability, increases your potential revenue earning. Next slide. So part of the 10 national standards for diabetes self-management education and support, in standard 8, there's a requirement for ongoing support, where that the participant and instructor develop a personalized plan, and then the instructor or the organization supports that person in achieving the goals in that plan. Well, that aligns exactly with the chronic care management benefit. So you could be meeting that standard requirement for providing ongoing support for persons that come through your diabetes self-management training program that you bill and receive payment for the benefit. Then you provide non-face-to-face or face-to-face support for that person to obtain the goals that they've established, and you bill that under chronic care management, and that's additional revenue. Next slide. Evidence-based programs in chronic care management can be provided ongoing health coaching to support the attainment of clinical outcomes, support for diabetes self-management skill development, patient self-managed support, improved health literacy, particularly since this can be done with support staff that are operating under the general supervision of the provider that allows for the billing to occur. And there was a change in the Incident 2 rules that allows for chronic care management services to be delivered under general supervision instead of direct supervision, which means that the community health worker, promotor, lay leader could be delivering chronic care management and not be in the health center, not be in the same vicinity or in the same building as the provider, but still be able to bill and receive payment for the service. They even went so far as to say that FQHCs and rural health centers could even contract with third-party organizations to deliver these services. And I'm working with a rural health center in Michigan right now where they've contracted with a third party just doing their chronic care management services, upon which they're then triggering reimbursement back to the health center. Next slide. So the role of a health coach. So the American Medical Association highlighted, they have a training for physicians that highlight the role of health coaches in the delivery of chronic care management services. And the American Medical Association suggests that sustainability of incorporating health coaches as part of the delivery model can be achieved through triggering payment through chronic care management. So we are following the standard best practice recommendation of the American Medical Association in utilizing health coaches as part of the delivery team under the general supervision of the provider to deliver health coaching, disease self-management. They're able to facilitate group, work with referrals, address social determinants, so the broad range of things that most health centers were accustomed to doing anyway as part of enabling services, which was always this phantom line on your UDS report that you never really got payment on. You kind of hope that it may mean more grant next year. But I know every time we did that, I was like, why are we doing all this to fill that enabling line? Because it doesn't mean money. But now that some of those enabling services could be reimbursed through the chronic care management benefit. Next slide. So eligibility for chronic care management, beneficiary must have 2 or more chronic conditions, and those chronic conditions must be may lead to worse health outcomes. Eligibility for chronic care management, and there's something else called complex chronic care management. That doesn't apply to FQHCs or rural health centers because there's one all-inclusive rate for chronic care management, which I'll highlight later. And there's a second benefit to address the behavioral health needs of a population called collaborative care management, which is also a service that can be reimbursed by FQHCs and rural health centers. Next slide. So this opportunity where a FQHC or rural health center can deliver services as non-face-to-face under general supervision. The Incident 2 rules have been changed, and it does require the establishment of a person-centered plan. That plan should outline some specific goals for that person, i.e. improve their ability to read labels, to change their diet, increase their exercise, all as part of improving their diabetes outcomes. And then the coach works with the beneficiary to identify the barriers they have to overcome. So at the FQHC I used to run, I remember very distinctly, I had 2 patients where the physician was just stressed out because at that time we were part of, many of you may remember long ago, the Diabetes Collaborative. So my FQHC was part of the Diabetes Collaborative. And I had some patients that were not getting improvement. And we kept going up and up on their insulin. And the physician was at their wits' end because their A1Cs were not improving. A1Cs were 12 and 13 respectively. I sat down with the beneficiary only to discover they worked the night shift. And the physician kept discussing how they needed to take the insulin in the morning. And they were like, when I take the insulin in the morning, I bottom out. So I just don't take it. And I said, but then you take it. For you, since you work the night shift, it's all in reverse. And he said, well, the doctor never said that. And that's because the doc didn't have time, because they're room to room, fast to fast, because on the other side, we're cracking the whip. I need more encounters. I need more encounters. So they're flying through the encounters, and they never took the time to find out that this beneficiary needed an adjustment to the way they're taking their medication to achieve the goals. At that time, there was no chronic care management benefit, so that time that was spent was not reimbursable. Today, if I was running my health center, I would have been billing for all the coaching and support I gave for that person outside of their medical visit as chronic care management, and then have that additional reimbursement to support my health center. Next slide. So target population, there are concerns CMS has had identified, many stakeholders identified that there's target populations that don't receive chronic care management. Those generally include minority populations, rural populations, and low-income populations such as dual eligibles. So again, if you are looking at a strategy where you may work with a health system that's under the total cost of care initiative, and there's this focus on diabetes, we then receive referrals into our center for our all-inclusive diabetes management program with ongoing health coaches. And now I'm triggering ongoing reimbursement for chronic care management in addition to my DSMT and MNT, all in support of the health system, which causes them to drive more referrals to my health center. And it becomes a win-win for both organizations because the government has already outlined that at least amongst minority Medicare beneficiaries, rural population, and dual eligibles, there is low uptake in the receipt of chronic care management services for those specific groups. Now, who better to serve those groups than FQHCs and rural health centers? Next slide. Some of the things that can be done as a part of a chronic care management benefit: health coaching, disease support groups, expanded health education and health literacy. So again, like the FQHC I was working with in the Mississippi Delta, when we developed a whole curriculum around how to manage your diabetes on a food stamp budget, we took those beneficiaries to the grocery store, and then we walked through and where they showed us what they generally bought. And then we looked at what the prices were. We established a menu and a budget that they were able to do over the course of the month. At that time, that was all gratis to the Medicare program. You know, we didn't get paid for it, but it was the right thing to do to meet the needs of the population. Now, if I did the same thing, those trips to the grocery store where I send my community health worker with the group and they learn how to read labels and they learn how to flavor their greens without ham hocks and other things that will lead to improved outcomes, I get to then build that under chronic care management where I could not build it before. Next slide. Under Medicare Part B, there's a list of chronic care management services. These include transitional care management, chronic care management, and behavioral health integration, and collaborative care management. One thing to note, some of the feedback I get from federally qualified health centers specifically is that the transitional care management benefit doesn't really assist them because they get the same all-inclusive rate. So what is the benefit of pushing to do the transitional care management business? Well, and the other challenge for federally qualified health centers was that there was a exclusion where if you did transitional care management during 1 month, you could not provide chronic care management during the same month. So again, why do transitional care management? Because then I'm excluded from doing chronic care management. So I feel I'm penalized, so I stay away from those services altogether. Do know that there are proposed rules that CMS has, the comment period has closed. It closed at the end of September. It does look very favorable because I talked to multiple groups that submitted positive comments in those proposed rules that if they are adopted as part of the final rules, they will go live January 1. They will allow for transitional care management and chronic care management to be delivered to the same beneficiary during the same month. So now you could be doing transitional care management and chronic care management and be paid for both services during the same month. And under the proposed rules, they said it would apply to FQHCs and rural health centers. We do have to wait with bated breath to see. Generally by November, we will see the final rules, and then hopefully it will become final. Then it would be adopted and go live January 1. Next slide. So these are the billing codes. So the billing codes, these 6 codes, are only for FQHCs and rural health centers. They do not apply to traditional providers because they have CPT codes for these services. So there's a general care management code that is G0511. So one of the things I mentioned briefly was there's a chronic care management benefit and a complex chronic care management benefit. It pays a substantially different rate for a traditional provider. What CMS has done for FQHCs and rural health centers is they've taken all the care management codes, they've averaged them out, and then that is the payment rate that a FQHC or rural health center is paid. However, a traditional provider, in order to get the higher payment amount, they'd have to do a full 60 minutes of service. For an FQHC or rural health center, they only have to meet the minimum threshold in order to receive the maximum reimbursement. So under this code, G0511, your community health worker would have to do at least 20 minutes of non-face-to-face support services for the beneficiary, and you would receive $61.27. So last time I looked, community health worker don't cost me $61 for 15, 20 minutes. So it definitely is a model that can be sustainable. And that is why we have been on a quest to get more FQHCs to begin adopting this as part of a delivery model, because it can substantially enhance your reimbursement for services for beneficiaries that you're probably helping in this way already. Just don't have it structured in a way where you're getting $61 for 20 minutes of work by a community health worker. Next slide. Behavioral health integration. So the behavioral health integration services also reimbursed, but it reimburses under the same code. So that beneficiary that has a diagnosis of diabetes, as many of you all know, that a common comorbidity of diabetes is depression. And if I don't address the depression, I'm not likely going to get improvement in my diabetes, because I'm so depressed because of my diabetes, I won't take my insulin. And the more I don't take my insulin, the worse my diabetes gets. The worse my diabetes gets, the worse my depression. So you should be able to address both. And in 1 month, I may be addressing the diabetes, using my health coach. The next month, I may do goal settings around depression symptoms, and I'm able to bill for 20 minutes of that time as well, again at the $61.27 rate. These services are billed once per person per month. Next slide. There is a psychiatric collaborative care management code. G0512 is the code. Now, that is for care coordination services that address a person's psychiatric condition. It does not have to be a seriously mentally ill diagnosis, but you should be your Access 1. So it does not have to be that. Any behavioral health diagnosis that's on the continuum counts, and services that are delivered could be billed, and these services can be billed in addition to chronic care management when collaborative care management is delivered. And you see that the rate is pretty substantial. So the FQHC rate for these services is $145. And if you were one of the grantees that are applying under the RFP, when I would provide intensive technical assistance, I would outline the requirements, how this could be added in, what would be required to deliver, all the way through setting up the business model and assisting with you testing not only the delivery of the service, the documentation to make sure it's compliant with the regulations, the submission of the claims, and then the tracking to make sure that you're being properly compensated for the services. Next slide. So there are some additional staff that's required for collaborative care management. As I said, I would go into great detail providing technical assistance to sites that weren't interested in the delivery of this. One thing that is very important to highlight is that collaborative care management is a code that is billed under primary care. It is not a specialist code, which means that a psychiatrist cannot bill for collaborative care management. The service was set up specifically for primary care to address behavioral health issues that impact the population that are seeking medical care in a clinic setting. And we need to get greater utilization of these services in the marketplace. Next slide. So outlining all of the care management codes, the all-inclusive rate discussion about how they're applied, and just again, highlight a note that if the proposed rules go final, chronic care management, transitional care management can be billed during the same month for the same beneficiary, which also substantially improves the business model. Next slide. Care management and coinsurance. Coinsurance and deductibles do apply with all the care management services. Coinsurance cannot be waived. However, as I stated earlier, you can apply the coinsurance requirement to the sliding scale. If a beneficiary has Medicaid as a secondary payer, Medicaid is required to pay it. Even though this is not a Medicaid benefit, they are statutorily required to cover it. Next slide. So care management services are definitely FQHC services. Recipient of care managed services are eligible for all services at the health center, including 340B. So again, another way of looking at your business model is I had a health center, at my health center, I had an education program where we did care management, complex care management for an HIV population. Those HIV patients would get one assessment per year, one clinical medical assessment, and then we would be doing care coordination with their HIV specialist over the course of the year. But all of their drugs came through my center as 340B. And so obviously that substantially improved my business model, as I was also able to put in that 340B revenue for the management of the drugs for those patients, because my care managers were managing medication compliance, and it was completely acceptable. In fact, HRSA highlighted as a best practice model. We had a team focused on medication compliance. They got their drugs through my 340B pharmacy, and then I knew exactly who filled, who didn't fill. I'd follow them all the way through, and then I had the full benefit of all the 340B drugs coming. The same thing could occur where I have this partnership with a hospital in total cost of care, referring patients into my program model for DSMT and chronic care management. Then they obtain all of their medications through my 340B program model, and then I also put my proceeds from 340B as part of my business model. So you see there's multiple ways to make this sustainable long term. Next slide. So the required elements for chronic care management, there first needs to be an assessment, a person-centered plan. The plan should address their medical, social, and psychosocial factors impacting their health, the interventions that will address those needs that were identified, and then tracking to see are we getting improvement of the things that we identified. Next slide. That care plan should include things such as education and outreach, support, care coordination, in-home assessments, medication reconciliation, health coaching. All of those things could be part of the delivery model. Next slide. Lastly, telehealth coverage. I know I've gone over this is the last concept I want to bring home. Next slide. So this is the listing of services that are approved for telehealth under the Medicare program. However, there is also a requirement that a person must be in a rural area in order to receive telehealth under the Medicare program. So both things would apply. However, DSMT and MT is a recognized service under a telehealth benefit. So because Medicare recognizes it as a telehealth covered service, I can go to a Medicare Advantage plan upon which all Medicare Advantage plans in the country have been approved to offer telehealth services as an expanded benefit. So if I were to approach a Medicare Advantage plan, I would automatically talk about how I can deliver diabetes self-managed training, medical nutrition therapy, and I can deliver that via telehealth for their population as an expanded benefit offering, particularly since Medicare has highlighted it as a focus area that's available under telehealth. The geographic restriction also causes complications of obtaining reimbursement under the Medicare program, but there is also work afoot to get that change at CMS. But as of today, it continues in place. The geographic restriction is in place. However, organizations that are what doesn't apply, but so you should be aware, under the new direct contracting model, there's going to be a waiver for telehealth services so that telehealth services can occur nationwide and even in the home. So that's important to know that CMS is warming up to the concept of expanding access to telehealth, even allowing telehealth services to occur in the home for a beneficiary. Next slide. Oh, one last thing. For organizations that do provide behavioral health services, we do know that as part of the opioid bill that recently passed, there is a geographic waiver for telehealth services for a beneficiary that has a substance use disorder. So if I have a person with a diagnosis of diabetes and they have a substance use disorder, I can provide telehealth services even in the home because of that change in the bill for Medicare beneficiaries. And most Medicaid plans, and in addition to that, there is a listing of that waiver in the state of Maryland as well. So under the Medicaid program, you could deliver services, particularly to a behavioral health or a substance use disorder population in the home or community setting. Telehealth generally requires real-time face-to-face audio and visual connection, kind of like a secure Skype. Do know that Skype does offer a secure service that's HIPAA compliant, but you have to know that you're using the HIPAA compliant version. The general version is not HIPAA compliant. GoToMeeting, it's actually a commodity now. A lot of organizations offer a HIPAA compliant service that could be utilized for telehealth, but you just have to be able to have real-time audio and visual. You cannot use store and forward. I did a project in Hawaii where they were able to use store and forward, but that only applies in Hawaii and Alaska. There is a billing technology modifier that does provide some enhanced reimbursement to cover technology costs. Next slide. So if you're not sure if your site is an approved location for telehealth, HRSA has a lookup table. You go to this HRSA lookup table, you put in an address of whatever location you want to provide services, and it's going to spit out yes or no, it's an approved location. If it comes back approved, I would maintain that as part of my record, as part of my file, to show that I went to the HRSA site, and as of the day I put it in, it was approved. So if I was questioned in an audit, then I'd be able to show proof that yes, I did do the service via telehealth. I checked to confirm, and HRSA confirmed that it was an approved location, at least at the time that I did the service. Next slide. So there's my contact information. So if there's any questions around the technical content, I'd be happy to explore those further. And even if an organization chooses to apply to the open RFP, those organizations that get approved under that RFP will get intensive technical assistance, but organizations that don't choose to apply or don't get approved, you can still get technical assistance through this initiative. So reach out, I'll be able to work. So the lady that was on earlier, Sue, she had to get off the call. So we are having some sessions where there will be general education and technical assistance that's provided to anyone who has interest, but the intensive technical assistance where I will be working with your teams on site to establish the business model, to look at the flow, to work with health systems, to talk with HSCRC, that would only be available to organizations that are accepted under the RFP. So I don't know if there's any questions. That's the end of the presentation.
Okay, very well. Thank you, Mr. McNeil. We certainly appreciate the very informative presentation that you have given us on the on the DSMT, Mechanics of Reimbursement and Role of Chronic Care Management for the FQHCs and the RHCs. Again, to all of our participants, we thank you and certainly have provided you an email or a telephone number that you may call for additional information regarding the presentation that has been provided. Thank you so very much. Have a great afternoon. This will end the presentation.